Okay, welcome to the second panel discussion today. I'd like to introduce our first speaker for this panel, which is Lieutenant Colonel Tuka. Lieutenant Colonel Tuka graduated from medical school in Budapest, Hungary. She enrolled into the Canadian Armed Forces in 2000. After completing the family practice residency program at University of British Columbia, she served as a general duty medical officer at One Field Ambulance in Edmonton. During that time, she was deployed to Kabul, Afghanistan. Following that, she completed the psychiatry postgraduate program at University of British Columbia in 2009. She has been appointed as the National Psychiatry Practice Leader of the Canadian Armed Forces in 2021. She has been representing Canada in NATO and UN working groups. Pleased to introduce Lieutenant Colonel Tuka.
Good morning, everyone. First of all, thank you so much for everyone who was involved in organizing this fantastic workshop. I am very, very happy and grateful to be here. And thank you very much for the introduction as well. So we all know that military sexual trauma is a highly complex issue since understanding the problem and the required solutions are extremely challenging. Many of you might find this content triggering, so I ask, please take your time, pay attention to yourself, and seek help if you need. In the next 10 minutes, I would like to give a high-level overview of the clinically relevant initiatives our organization, the Canadian Armed Forces, implemented or will implement to address military sexual trauma. And I also look forward for the discussions, and I look forward to learn from all of you. I do have nothing to disclose. And just very briefly, in terms of the definitions, in the Canadian Armed Forces, we mainly use the term sexual misconduct, which encompasses sexual assault and sexual harassment experienced during military service. And it is essentially the same as what the US Veteran Affairs defines as military sexual trauma. So during my presentation, I will use sexual misconduct and military sexual trauma interchangeably. So military sexual trauma, MST, is an experience. It is not a diagnosis, but it impacts the victims' lives and military career. And it also has a corrosive effect on discipline and morale in an organization. We also know that not everyone who experiences MST develops long-term health consequences, but we also know that MST increases the likelihood of mental and physical health problems and readjustment challenges. MST is an interpersonal trauma suffered from a person in trust, from a person the victim works with, supervised by, deployed with, or relies on in dangerous situations. And now the victim can ask how it could be tolerated in my organization, how it can be ignored, how it can be how it can be mishandled. So MST is associated with a great sense of interpersonal and institutional betrayal. It is important to make a distinction between disclosing and reporting. Disclosing means to telling someone that what happened, usually to break the silence and get support without a formal investigation initiated. On the other hand, reporting to the police or to the chain of command typically leads to a formal investigation. Our first external review from 2015 highlighted that sexual misconduct has been significantly underreported in the Canadian Armed Forces due to fear of career implications, fear of lack of confidentiality, fear of impact on relationships in the unit, amongst many others. Consequently, the Canadian Armed Forces released the Sexual Misconduct Response Policy in 2020, which expects that all Canadian Armed Forces members, which inherently includes the victims and their confidants, have to report to the proper authority any sexual misconduct committed by any person in the workplace or on the defense establishment. However, further external reviews recommended to permit exceptions to the duty to report policy to allow victims to report when they are ready to do so, to avoid further victimization and increase the victim's sense of control during the reporting process and investigation. In the Canadian Armed Forces, the sexual misconduct started to unfold in 1998 with articles published in the popular Maclean's magazine um, when 13 women were interviewed and said that they were victims of sexual assault in the Canadian military and their cases may represent a pattern of sexual misconduct in the service. Most of those incidents took place in the 1990s after the military began to fully integrate women into the armed forces. As a response, initiatives such as new military investigative units were rolled out to address the issue. However, in 2014, the L'Actualité news magazine again headlined a report that sexual misconduct in the Canadian Armed Forces was still an ongoing problem. And 2 weeks later, the Maclean's magazine followed with a story that echoed its finding in 1998. So this is a very busy slide, which is very good because it shows all of the programs, services, external reviews and recommendations, multiple surveys and legislative and policy changes that have informed and shaped our organization's effort to address sexual misconduct and its consequences. I will now highlight a couple of those initiatives which have significant clinical relevance. The first and most important initiative was the establishment of the Sexual Misconduct Response Center, SMRC, in 2015. The SMRC is part of the Department of National Defense, but it is independent from the Canadian Armed Forces chain of command. The primary role of SMRC is to provide support to Canadian Armed Forces members affected by sexual misconduct. The support is confidential, can be anonymous, comprehensive, and timely. If members request, the military liaison team can provide in-depth information on reporting sexual misconduct within the Canadian Armed Forces, the military justice system, and Canadian Armed Forces policies. SMRC work in partnership with the Canadian Armed Forces to increase understanding of the extent and consequences of sexual misconduct. It also provides advice on policy development and participates in different research activities related to the sexual misconduct. In 2016-17, several former Canadian Armed Forces members filed class action lawsuits claiming damages for gender discrimination, sexual assault, and harassment during their military service. A settlement was approved by the federal court in 2019. The settlement provides the class members, the victims, financial compensations and also offers voluntary participation in the Restorative Engagement Program. In the Restorative Engagement Program, the victims, the class action members, can share their knowledge and understanding of sexual misconduct and its causes and impacts. The defense representatives who came from different grades and higher ranks of the Canadian Armed Forces have opportunity to acknowledge understand, and learn from class action members' experiences of sexual misconduct and take responsibility as an organization of its causes and responses. So it is an opportunity for the class action members and the defense representatives to identify lessons learned and contribute to a broader culture change efforts in real time. The restorative practitioners facilitate the communication between the victims and the defense representatives in a safe and respectful manner outside of the Canadian Armed Forces. It is important to note that the restorative engagement program does not facilitate communication between class members and those who directly harm them. Instead, it involves representatives of the institution in which the harm occurred. I would like to also note that the Minister of National Defense made an exception to the duty to report policy in the context of the restorative engagement program. The settlement and the restorative engagement program are important contributions to the victim's healing process, as besides being heard, acknowledged, and validated, the victims can feel an increased sense of empowerment, and also they can feel that the issue of the institutional betrayal is being addressed. Victims of MST often describe a sense of isolation when they're trying to access existing civilian peer support services, as the specific military aspects of their experiences, such as the role of military culture and the institutional response, are not well understood. Our MST peer support program is being launched through a phase-based approach and eventually will offer peer support in many different ways and formats. The victims, according to their needs and readiness to participate, they can choose from online, virtual, and in-person options, one-in-one or informal or formal groups. The peer support programs are safe and it can be anonymous. It increases the awareness of the available resources and provides sense of empowerment and self-efficacy. It decreases the isolation, stigma, and shame related being a victim of MST. It also provides support between the therapy sessions. So in closing and looking ahead, we need to continue to demonstrate cultural humility and strengthen the existing victim-centered responses. We also need to practice trauma-informed approaches to successfully protect and help the victims of MST. And thank you very much for your attention.
So next, I'm pleased to introduce Dr. Holly Hoffmeyer. So Holly N. Hoffmeyer, PhD, is a clinical psychologist by training and serves as the program manager for the Defense Health Agency's Sexual Assault Behavioral Health Clinical Intervention and Inclusive Behavioral Health Program Management Office at Medical Affairs. She serves as co-chair of the Joint Executive Committee's Sexual Trauma Working Group, co-chair of the VA-DoD Women's Mental Health Mini Residency, founding chair of the DoD Behavioral Health Diversity Working Group, and executive director of the DoD Sexual Assault Advisory Group. She specializes in the psychological consequences of trauma, evidence-based psychotherapy, and serves as a proponent for marginalized communities across the DHA. Dr. Hoffmeyer?
Good morning. Thank you for coordinating this conference today, and thank you for letting me be a part of it. So let's dive right in. So I want to let you know that these are the opinions of myself. I do not represent the policy of the United States government nor the United States Department of Defense. So today I'm going to provide an overview of gender disparities. I'll introduce my working model of gender-sensitive care, and I'll tell you about our biggest effort, the VA-DoD Women's Mental Health Mini Residency. So overall, women constitute approximately 16% of the active component of the United States military. You can see there it's broken down by branch. Here we have a summary of the incidence rates of behavioral health disorders by category and sex across the active component. So in orange, we have the females, and in blue, we have the males. And if you look at the diagnostic categories going from left to right, you're going to see, I believe, adjustment disorders should be the largest one, and then followed by alcohol and substance use, anxiety, PTSD, and depressive. And the other disorders are much less common. So this is just an overview of some recent data. I want you to draw your attention to a couple of things, and that is that women have nearly double the adjustment disorder rates, as well as double the anxiety and depression. So that is a significant disparity that we see there in the behavioral health realm. These continue to see the gender disparities in unwanted sexual contact. So I want to discern here between unwanted sexual contact, which does include sexual assault, and also sexual harassment. So the rates we see here, we see that for active duty males, approximately 1.5% reported or disclosed unwanted sexual contact, whereas 8.4% of women are disclosing unwanted sexual contact. We see that trend continue with sexual harassment on the right-hand side. Again, 7% of males are disclosing sexual harassment, whereas 29% of women are disclosing sexual harassment in the workplace. So these rates are very distressing. It may be cold comfort to note that the rates for civilian data are actually higher. So for women, 18% are disclosing sexual assault, whereas for civilian men, 3%. Again, approximately double the rates we're seeing in the DoD. Could be that we're just better at tracking the data, but I want you to realize that there's a significant issue nationwide with sexual violence. So I'd like to take a few moments to share a little bit about my working dynamic model of gender-sensitive care in the military. In my opinion, these different boxes are basically domains or areas of content knowledge. So we have here in the upper top left an awareness of gender disparities. So realizing that there are differences in the rates of depression, anxiety, adjustment disorders, etc., across for women and that are different from males. And then having some knowledge of how the gender may impact the presentation in session, how may the gender impact the etiology or the development of the disorder. So when you see someone in session, you may say, oh, with this cluster of behaviors, I'm thinking it's this, but you're not always acknowledging the role that gender plays in that mental calculus. So I want to also bring up reproductive mental health. We had a full panel on reproductive mental health, so the role there I think is clear and apparent. At this point, we're focusing mostly on women's reproductive mental health, but in time, hopefully we'll get to work with males and the gender diverse as well. And then finally, because it is a military model, I want to bring in the idea of trauma-informed care. Knowing that the rates of trauma exposure are rather high for this population, I think it would be negligent to not include trauma-informed care in our gender-sensitive model. And for those of you who aren't familiar, think of gender-informed care as trauma-informed care as being a shift from what's wrong with you to what happened, how can I support, how can I help, how can I align with your values. So it's a different kind of approach to healthcare. And then all of this is laid on the backdrop of the intersectionality and the minority stress that many of us face. So what does this look like for a younger woman, or an older woman, or a woman of color, or someone who's a combination of more than one of those things? So we look at this as kind of setting our pace for gender-sensitive care in the military. So currently we have a number of efforts to implement evidence-based practice. We are data-driven. And so we have the reproductive health DoD that was mentioned earlier. It is a multidisciplinary effort, and it's going quite well. We have the new reproductive mental health consultation pilot. This is a very exciting effort that we are doing in collaboration with our VA colleagues. So that is currently in the memorandum of agreement stage. We are hoping that that'll be signed in the next few months, and then we'll be able to actually start the consultation service and when the weather warms up. So the other couple things I want to tell you about are, again, our colleagues in the WIC who are extraordinary, including Ms. Hart, created the Behavioral Health Screening and Referral and Pregnancy Practice Recommendation, which is super helpful and just a great resource that I often share with colleagues in behavioral health. And then, of course, our biggest effort, the VA DoD Women's Mental Health Mini Residency. Again, a collaboration with our colleagues in mental health, women's mental health at the Department of Veterans Affairs. So I want to give you a little bit of the history of the Women's Mental Health Mini Residency. So the first year that the DoD participated with the VA was 2018. That was well attended, and we got some very positive response. And at that time, we determined to have a biannual cadence for the VA DoD collaboration. So in 2020, we had the pandemic, as you may recall. That did not go well for us. We weren't able to pivot in time, and so we had to cancel. And then in 2021, we did a virtual experience. And then last year, based on feedback, we did a workshop series of 2-hour, more in-depth sessions. So that talks a little bit about the workshops that we took place, again, small groups, about 30 to 35 people per session, and they were more in-depth details. So we did have a couple blips there with attendance. We were hoping to 30 to 35 people. We had a couple that went well over that. Apparently there was a back door in the premium program that we didn't know about, and people were able to sneak into the sessions. So that's okay. Where there's a will, there's a way. And so we had some great feedback. Mostly, nearly 80% agreed that the information was useful and that the skills were gained that could be used in their work. We also had feedback that reflected very specifically content that was specific to military populations, information about race-based stress, information about gender-affirming care, and then just generally knowledgeable and engaging faculty that made it a pleasure to learn new content. So the 2023 mini residency is on track. We are looking at June of this year, hopefully in Seattle, hoping to confirm a venue soon. We're hoping to invite 200 DoD and VA clinicians to share in this learning experience. We're also going to have a poster session where it's actually the clinicians bringing forward their best practices, what they're doing in their own clinics to make care more responsive to women and gender diverse in their clinic. And then, of course, several selected and invited speakers who are national experts across the country, including a great plenary on lifestyle medicine, information again on health disparities, gender affirming care, and then also ostracism, which is unique, I believe, to women. So I have here some guidance about helping to increase clinical cultural sensitivity in your clinic. So again, get resources, get involved, get engaged, go out and meet people from different cultures, learn about what they want, what they need, and learn more about culturally sensitive care. So at the very end, we have some more resources that are government, so please feel free to use these widely and distribute. And I believe that is the end of my time. Thank you so much.
I'm pleased to introduce our last presenter for this panel, Dr. Kate McGraw. She is the Chief Psychological Health Center of Excellence at Defense Health Agency. She is a clinical psychologist and former active duty U.S. Air Force missile officer and psychologist. Her work over the last decade has included a focus on mental health needs of military females and veterans. She'll now present on research related to women's mental health in the U.S. military, including a review of the development of research strategy over time, and a review of what relevant research is now underway in the DoD. Dr. McGraw?
I'm going to have a lower mic as well. Thank you for that kind introduction. Bonjour. Hello, everybody. I'm really honored to be here to speak to you all today. I'm so excited to talk to you about what we've been working on over the last decade. I'm going to see if I can make the slides roll. Okay, so I'm going to tell you that I'm not speaking on behalf of the government, that I've got no financial interest to disclose, and that there's no conflict of interest that I'm going to have while I present this information to you. So we're going to talk today a little bit about what the Psychological Health Center of Excellence, our role is, what we do, some of the efforts that PHCOE has supported in women's mental health, a little bit about our Defense Health Program funded women's mental health research portfolio, and how we develop our strategic plan. I kind of formed this briefing in a way of telling a story and also helping set the stage about how we have arrived where we are and what steps took place in between. So the mission of the Psychological Health Center of Excellence, we were congressionally mandated and have come under at least two other names, the Defense Centers of Excellence for Psychological Health and Traumatic Brain Injury, the Gulf War Center, and the Deployment Health Clinical Center have all combined under the Psychological Health Center of Excellence. And we really want to be the go-to place for research answers, advancing excellence in psychological health care in the DoD. These are our strategic priorities because you don't know how to get where you're going unless you have a map. And so these are the goals that we have. Number one, we want to support the services and combatant commands, improve care quality and access. We do this by implementing pilots, translating research into practice, looking across evidence in multiple data systems, and using experts across federal agencies and within DoD to advance science. We're also now developing the strategic plan for all Defense Health Program funded research looking at psychological health, and executing our own health services research. I think Kimberly earlier mentioned the health-related behavioral health, or the health-related behavior survey. So our center is actually leading that effort and incorporating some of the questions that we talked about earlier. And then finally, a very important goal, which is fostering our own organizational development, because people are the most important part of the team. So I wanted to give you a little bit of context very briefly. Back in 2010, the VA and the Veterans Affairs Department, Veteran Affairs, and DoD got together and identified that there were some huge gaps in the way we were looking at women's mental health, and also the mental health needs of both men and women who experience sexual assault. So we had a work group put together. I was the DoD lead, and Dr. Susan McCutcheon was on the VA side. And we were tasked with trying to figure out what were the gaps in both policy, in programs, and in research. And we pulled together service members and veterans, SMEs, and we worked for several years trying to figure this out. During that time, we also wrote a report to Congress on PTSD, and we identified that we really don't understand the mental health needs of minority service members, to include women, but not just to women only. And we recommended that more research needed to be conducted. And so part of our tasking was to study where the gaps were. And so we did look to see what are we funding within DoD, and also what's been published in the literature. And so we actually did a comprehensive review of all of the research, and that was part of the tasking that we did. We did have a separate portfolio for women's health research at one point, but then there was a decision made somewhere to distribute the studies across various different portfolios, and so that everything was kind of rolled into one. But in 2020, both the Secretary of Defense and the Secretary for Veterans Affairs really emphasized an increased need, both focusing on mental health, but also on the needs of women service members. And so that it's almost like we've reached a tipping point. And so as I was driving over here today, trying to reflect on, what important messages I wanted to impart is one is you get a group of really passionate people together that are intent on making a difference, and you stick with it over a number of years, good things can happen. And I think that the folks that are speaking on behalf of the DoD today, you can definitely measure progress over time, but it does take time. So the statistic, it ranges between 15 and 20% of the force is female, but that's based on which component of the force you're looking at. And so our work group looked at and conducted a summary literature review in 2011, and then we refreshed it in 2018. And in that summary literature review, we were looking across all published research, and what we identified was that there's maybe some research on women veterans, but active duty service women, mental health issues, very, very little research to start with. And then what we were actually funding was really, really minimal. So in 2018, there were only 2 Defense Health Program funded studies with solely female population. And there were a number of studies that allowed for post hoc analysis for the gender differences, but no specific populations. And as a result of the work that this work group did, informing the portfolio prioritization, now I can say that there are actually 16 studies with female-only populations, with an additional 8 studies examining gender differences. And I thought it would be interesting to talk about those. So I'm going to review some of the titles in just a bit. Within our center, we've sponsored the first ever look at the behavioral health needs of minority active duty service members through the RAND Corporation. We funded a study that was published, and that's a really great read if you're looking for information about that. And then we do a number of other, not basic science, not randomized controlled trials, but health services research, and also looking at identifying through our own experience what areas need to be focused on. So earlier there was a question about lived experience informing the work that we do, and I just wanted to share the publication at the bottom is mine, and this is my own look trying to pull together various disciplines research looking at social support, ostracism, and pain perception amongst women in the military, and if there's some type of connection there. And if you think about that, from my own experience as a missile officer, it was more important to us to fit in with the rest of the group when there were 6 women and 200 men. And so that made me think as a scientist, like, is there something there about being excluded or being included that affects our mental health? Since that paper has come out, now we are funding actually a study in our portfolio looking at ostracism, and there's also been a follow-up randomized control trial to test that theory. So that's just an example of one of the ways that we inform our portfolio. These are the funded studies in women's mental health now that the Defense Health Program is funding, and I'm not going to read every title because that would probably really bore you, but you will have access to the deck and you can kind of scroll through. There's a wide variety of topics, including the impact of sexual assault, reproductive health, postpartum impact, deployment risk factors for maternal depression, and using beta blockers to block memory reconsolidation in female veterans. And so in terms of how we develop our plan, our strategic plan right now is in development, and we've brought in stakeholders from a number of different federal agencies to look at how are we conducting research that prioritizes assessing, protecting, sustaining, and optimizing psychological health. And then we identify if there are gaps in what we want to develop, and then how we fund it. We prioritize it based on whatever the key components are that have been identified through subject matter experts and senior leaders. And then we fund and translate in accordance with those priorities. And I'm happy to say that part of our strategic plan does include a focus on minorities, which includes women service members. So that is a little bit about our center, a little bit about what we've been doing, what the Defense Health Program is funding, and how we develop our strategic plan. So that summarizes my briefing, and I'm happy to take questions. Thank you.
I'd like to invite the presenters for this panel to come on up here for a Q&A. Should we go ahead and start with an online question?
Yes. So
Okay,
we have an online question from Major Rita Ryan that came up during Lieutenant Colonel Tuka's presentation. The question is, to clarify understanding, the current DoD mandates that a service member reports a personal MST. Are there outlined consequences if a CAF member does not report their MST?
Can you hear me? Yeah, it's a. Thank you very much for this very interesting question. I actually looked at up that what would happen for an individual who is not reporting. I did find an answer, if you wish, in one of the external reviews, which was looking at the military justice system. And the answer was that they didn't find anyone sort of significantly punished if they did not report. But yes, this is an issue, and this is why this report, this external report looking at the justice system and the reporting system, actually recommended but I put it into my slide to abolish this because it did not achieve its intention. So I cannot tell you that how many people are not reporting. Obviously, it's as I said, it's underreported, but I am how should I say that? I don't think that people have been significantly punished. I don't know. The Surgeon General can um, 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 confirm that, but I don't think that people are again significantly punished for that. But it's an issue. It's an excellent question, and some of the recommendations are that definitely make an exceptions for the victims and the confidence for sure who the victims are disclosing what has happened.
Thank you. We have a question over here.
Good afternoon. Thank you for all the briefs. Liz Erickson from the U.S. Air Force. See the graphic in Dr. Hoffmeier's brief about the difference in diagnoses of mental health conditions between men and women. I'm wondering what are the thoughts on how much of that is potentially in differences in care-seeking behavior? So part one of the question. And then I'm curious, maybe for other experts in the group, if we see any changes in those disparities of the diagnosis rates in military versus non-military populations, and then also in between different countries, as there might be cultural differences in some of that care-seeking behavior. Thanks.
So I'm going to unpack that. So the first thing is, yes, there are differences in help-seeking behaviors, and that is not just by gender, which is a social construct, but that's also, yes, there's differences. It's not just based on gender, it's also based on culture. So for some cultures, it is not okay to seek outside help. And so all of those factors play into the help-seeking behaviors. So yes, you're right, that's a great observation. And then in terms of outside of the military, I am so focused on what we're doing in the military. I'm not looking up very much to see what's going on. But I will let other speakers, if they have other comments, other questions. Oh, I'm sorry.
Yeah.
I got it.
So there's a correlation, but we don't know what the causation is. I guess I could say that. And that's why we need more research. So we have the data. We've noticed that there's a disparity based on the numbers, but we don't know why that disparity exists. We need more research.
Thank you. I'd like to go to another virtual question.
Yes, thank you. So this is a question from Commander Casey Campbell. And she says, as a woman with 26 years in a CAF, what are we doing for the healthcare providers who have experienced MST? Counter-transference is possible to both those accused as well as patients who are discussing their MST. What can be done to tailor MST support to caregivers who require care for MST and are expected to provide care for MST to others?
So thank you so much. Again, this is an excellent question. One of the initiatives, what I didn't mention because I just had only 10 minutes, what is underway is through SMRC that providing fundings to different civilian services, clinics, academic institutions who could provide services for our members. So MST or trauma, it's again highly personal, and as I mentioned, some people feel institutional betrayal after experiencing MST, and they prefer to seek treatment outside. So we definitely honor that and give the options for our members to seek care outside of the CF health services. And with that initiatives, we try to improve access to care, timely access to care outside of our health services. The other part of the question, the transference issues, counter transference issues, it's absolutely very valid. And what I can say about that I highly encourage the clinicians or the personnel who work in the Canadian Forces Health Services and provide care or in touch with patients in any way to seek help.
Thank you. We have a question in the room over here.
Ma'am, first I wanted to thank Colonel Erickson for her question. So mine's a little more of a follow-up on that. So in the review while she was talking, I had been looking at the relative risks of anxiety and depressive disorders in the U.S. general population versus the military, and the relative risk is somewhat similar. In y'all's research, have you seen any difference in the clinical course or treatments based on trying to identify that disparity for the military in particular?
That's a really specific question, and I don't know of any research, but I'm happy to check and get back with you. So if I can get your contact information, we can do some look. We'll look into it and find out the answer for you.
We're going to go to a virtual question.
So we have a question from Major Rita Ryan again, asking for more information regarding the 2023 VA DoD Women's Mental Health Mini Residency Program. Where can she, or where is more information available on this topic?
That is a great question. So at this time, we are currently working to secure a venue within the greater Seattle area. We are considering other locations because we do have a federal limited budget. So what I can tell you is that there is a shared mailbox. If you can send me an email afterwards, I will send you the information about the shared mailbox. But we will be opening pre-registration probably in the next 10 days or so. We have to confirm that all of the DoD registrants are actually active duty, civilian, or contractors who are actually working with clinical care at this time. And then we will have them registered. The good news is that it's 16.5 CEUs for most professions at no cost. So if you can get your institution to fund your travel, we welcome you and look forward to seeing you.
Thank you. Do we have any more virtual questions?
There is one last one, and the question goes like, what are some ways to protect those who comes forward with evidence but ended up with their case being thrown out over time due to lack of sufficient evidence and that now have been lost, henceforth leaving the solution of relocating alleged perpetrator as the best step? So the question would be, what are the ways to protect those who come forward?
Okay, so I didn't catch it. Can you just repeat the question?
So the question goes like this: what are some ways to protect those who comes forward with evidence but ended up with their case being thrown out over time due to the lack of sufficient evidence that have now been lost?
So thank you for the question. I can answer for this question as a clinical point of view, that when you are a clinician and you are treating a patient who comes forward with any type of trauma or any mental health symptoms, we are not looking at for evidence that it happened or not. We take it face value and look at and treat the experience what the individual disclosing and talks about. And so if let's say the evidence turns out that it doesn't stand anymore, the individual is still suffering, or we provide treatment for that. And also, I would like to mention that people who suffer sexual trauma in the military, um, obviously, I'm not minimizing the impact of that, but many times we find out that those individuals, unfortunately, traumatized even prior to that. So we are dealing with a compound effect of multiple trauma, and we do see this individual as a patient who is suffering, who has symptoms, who has signs, and who has functional impairment. So, on clinical point of view, definitely we continue to treat this individual, and obviously we consider the potential emotional consequences of finding out that her experiences didn't get any legal consequences. We did see patients or members with those kind of issues, and again, in clinical point of view, we continue to support them.
Thank you. Are there any other questions in the room?
I just would like to ask that this mini residency, is it available only for US people or international?
Great question.
I feel a little on the spot, but in the interest of international relations, we'll try to work something out.
It's very appealing. Thank you very much.
Okay. Oh, we have one last virtual question.
Yes, it's a follow-up question from Lieutenant Hu. He asked a follow-up question. So if a serious sexual trauma happens in a remote/austere environment, what policies are in place to potentially collect any time-sensitive evidence?
So if a military sexual trauma occurs in an hostile remote environment, what is the
What policies are in place to potentially collect any time-sensitive evidence?
I don't know that I can answer for this question. In clinical point of view, I'm sorry. Do you
Seems
guys
like
have
that
any
might be more
comment?
appropriate for like forensic collections.
Yeah. Well,
Yeah, it may be different between Canada and the US, but we have a number of policies that oversee forensic healthcare, how we collect evidence, how we manage it in any environment, forward or back stateside. So it may be part of it is a forensic solution and part of it is clinical, and sometimes there's an intersection there.
thank you very much.
Will you allow a last online question? You have
Yeah,
one?
let's
Okay.
go for it.
So last question for Colonel Bennett from New Zealand. There's increasing focus on programs for care and support for those impacted by inappropriate sexual behavior in the military and restorative justice. Are we also making headway in prevention? And what do you see as key to creating culture and behavior change?
First of all, hello, Colonel Bennett, if you're from New Zealand. But we do have research in our portfolio that actually focuses on sexual assault prevention and response from a mental health perspective. And then our sexual assault prevention and response office has their own portfolio where they're trying to address military culture, and they approach it more from an operational standpoint and from a legal standpoint, as the Defense Health Program research dollars look at it from a medical standpoint. Do you want to add?
I did just want to add that there's research that shows that for those environments that tolerate gender-based harassment, that actually also allows sexual trauma to flourish and other forms of sexual violence. So in part by changing the culture, we are in fact engaging in prevention work.
I just would like to echo what my two colleagues said, that in the Canadian Armed Forces also we pay a significant attention for culture change, education, and prevention.
Okay, thank you. And I want to thank our presenters for their fantastic presentations today.